All right. Hello, internets. Welcome to the LARVOL Onco Data Podcast, our every Friday podcast. I'm Mark Gramling. I'm the VP of Oncology at LARVOL, where we focus on data solutions and AI solutions servicing the healthcare industry and pharmaceutical industries. And we like to take Fridays to talk onco data in the shortest podcast that there ever was, only 15 minutes. But hopefully can cover as much ground as possible. I'm really happy to have Dr. Sonpavde joining me today. He's been on our podcast maybe end of last year around ESMO, I believe it might have been, but he's been kind enough to come back today and take a look at CLIN and take a look at maybe some of the most recent results in GU oncology. So if you'd be so kind, Dr. Sonpavde, to introduce yourself to the podcast and our listeners here, and we can chat from there.
Thanks, Mark. So I'm in Orlando, Florida at the Advent Health Cancer Institute. I lead the GU Oncology program as well as the phase 1 clinical trial program here in Orlando, Florida.
We appreciate that. And another, I think, maybe more minor claim to fame. Obviously, Dr. Sonpavde is one of our quote influencers, amongst the oncologists that we track on our CLIN oncology platform. And I may just bring up CLIN just as a share screen. We've got a couple new features, and then we could chat from there. So let me pull that up, and it'll go right into talking about some of our reactions today from recent disclosures. So I will present. And there we go. Hopefully my screen is visible.
Yes.
Thank you for confirming. So we'll definitely, we just want to sort of discuss some of the key findings, maybe from ASCO GU itself, but just wanted to introduce for the podcast today. We're pretty excited about having a couple new features in terms of the sentiment analysis that we do in CLIN. So if you follow us on social, you've certainly seen before where we have negative, positive ratings, but we've expanded our AI capabilities to have more parsed sentiments. That's now available on CLIN for those who want to check that out. So that's what you're seeing here is having, again, the sentiment being applied to oncologists, including my guest here today, how they're reacting to disclosures from ASCO GU. So if you follow us on social or check out CLIN, you'll be seeing that these are broken up a little bit more. And just to also highlight maybe one new feature, and I think we'll probably talk to TALAPRO first and then chat from there, just to highlight a couple new elements, is we also have some new visualizations for this type of sentiment reaction in CLIN. So what you're seeing here from a big step back perspective is sort of, from our own analysis within CLIN and incorporating social media reactions, how a trial is considered as being ranging from, you could even say, failing to being practice changing. And we've developed a number of new analytics enumerating the number of posts on Twitter, aka X, and parsing out the reactions a little bit more. So I guess I have to do the salesman thing a little bit every once in a while on the podcast, but I thought we could just, because we're dealing with an expert here, to talk to maybe 3 of these coming out of ASCO GU, and maybe we could just start with TALAPRO within, Tala plus Enza combination therapy versus Enza. This is presented at ASCO GU, and maybe we'll start there and sort of seeing your thoughts on, are our analytics right from practice changing or positive or neutral or mixed? We can go from there.
Yes, I think that your impact of TALAPRO 2 is broadly correct. So let's talk about TALAPRO 2. So this is a phase 3 trial done in the first-line setting of patients with metastatic castration-resistant prostate cancer, mCRPC. And so this trial is already out there and reported to be positive, of course, for radiographic progression-free survival in patients with HRR, homologous recombination repair alterations. And this, of course, led to US FDA approval in patients with mCRPC and HRR alterations. Now, what was shown at the GU ASCO symposium is there was an overall intention to treat cohort. This is regardless of HRR alterations, where patients were randomized to enzalutamide plus talazoparib or enzalutamide plus placebo. And so in this report at the GU ASCO symposium, this overall intention to treat analysis for survival was actually positive for the addition of talazoparib to enzalutamide. The hazard ratio for survival was approximately 0.8. And so you can say that the trial basically met its secondary. This is a secondary endpoint. The radiographic PFS was the primary endpoint. So it now met the survival endpoint in the overall intention to treat population. And so the question for the field is, does this change its application in the clinic? Because in the clinic, this combination is now currently approved only in patients with HRR alterations, and that was based on radiographic PFS. And incidentally, at this meeting, there was also a separate poster looking at specifically the HRR population, where also there was a more impressive improvement in survival. So the question for the field is, does this change the label? And what does the FDA do with this data? So we'll need to wait and see. The field is still scratching its head. Clearly, the benefit is more impressive in the HRR population, but there was an overall survival improvement with a hazard ratio of 0.8 in the overall unselected patients with or without HRR alterations.
I may be misremembering, but I thought I saw a lot of people calling out maybe the median OS. Was the median OS improved? I thought people were calling on the order of 8 months or something to that effect. Or am I confusing that with the hazard ratio of 0.8?
That's right. The hazard ratio was approximately 0.8. The median
Okay.
OS, you're right, was about 8 months. So 37 months versus around 46 months.
Okay.
So
Yeah.
close to 9 months. So you're right about the median survival being around 9 months improvement.
Well, I guess we'll collectively keep our ears open as to what this impact is on the label for a non-HRR population. So you can certainly see why TALAPRO was at the top of our proverbial list for most reactions. So
And of course, the food for thought here is that the other combinations are approved only in BRCA1, BRCA2 altered populations. The olaparib, abiraterone, niraparib, abiraterone combinations are approved only in BRCA1, BRCA2 altered patients, not even HRR, which is a broader label for enzalutamide talazoparib. So now, does these data here change anything for enzalutamide talazoparib? We'll need to wait and see. I'm skeptical that it will change the label because, again, one of the things is we were all a little surprised by the way the FDA interpreted data in those other trials. But I think that especially the olaparib abiraterone data, where the approval came only for BRCA1, BRCA2. Remember, even in that trial, in the overall intention to treat population, the trial was positive. But on sub-analyses, it's clear that most of the benefit was in the BRCA1, BRCA2 altered population. So I think that we need to sit back and wait and see how the discussion evolves and see what the regulatory agencies think about the recent update from TALAPRO 2.
this is a completely naive question, or maybe it's just a statement that it's sort of inversion, that you'd be looking with olaparib, that you'd be looking at ITT. I guess the analysis was sort of reversed. If I am understand what you're saying correctly, that if you go here and then you go to BRCA, and BRCA is where it's more effective.
Yeah.
But in the case of the TALAPRO study, the primary endpoint was designed around HRR. There, I don't know if there's a question or a statement there, but it sounds like it was designed sort of differently. Does that make sense?
That's right. It was designed differently, but there was a secondary endpoint to look at the intention to treat population. And if you recall from the abiraterone olaparib trial, that had an endpoint of intention to treat overall population, where it was positive for RPFS. But there's no doubt that when you look across these studies of PARP inhibitors, that the benefit clearly is concentrated in the BRCA1, BRCA2 the most, followed by the other HRR alterations. There was preclinical data that the combinations might be additive, at least even in patients without HRR, because of these two pathways, the AR pathway and the PARP pathway intersect. So inhibiting both had some rationale behind it based on preclinical data. But there's no doubt when you look in the clinical trials, the BRCA1, BRCA2 altered populations are the ones that benefit the most clearly, followed by the other HRR, and followed by maybe a small hint of a benefit in the non-altered population. But the data are the data. So this is what the TALAPRO trial shows.
Well, I appreciate that. Maybe we could. I promised we'd hit on two or three, so maybe we'll rapid fire along. But right on the top end of our analytics was also the NIAGARA study. I think last time you were joining us on the podcast, we had a long form podcast around ESMO, and that was the topic of conversation. But there's additional efficacy and safety data coming from NIAGARA. So maybe my next question would be your reaction to that observed. Well, I just said additional longer term efficacy, Dr. Sonpavde.
Yeah, so to recall, the NIAGARA trial is a phase 3 trial that for the first time showed that the addition of perioperative durvalumab, so both neoadjuvant and adjuvant durvalumab, to neoadjuvant cisplatin gemcitabine chemotherapy improved both event-free survival and overall survival. So in the overall trial, this was a large trial, a little over 1,000 patients. So the event-free survival hazard ratio was around 0.68. And for survival, the hazard ratio was 0.75. So what was shown here at the GU ASCO symposium is essentially some of the sub-analyses, essentially confirming that there was a benefit seen for EFS and survival. Now, the PATH-CR was a co-primary endpoint, but the way the trial was designed statistically with the splitting of the power, the difference in the PATH-CR between the chemodurvalumab versus chemo group was not statistically significant, but there was a numerical improvement from around 27% to 37%. Now, what was shown at the GU ASCO symposium is that there's always been a question of the adjuvant component, and this really is hard to tease out. But what was interesting was that the investigators looked at the benefit of adding the perioperative durvalumab component. Remember, it was a year of durvalumab, approximately 3 months pre-op and about 8 months post-op. And what was seen is, regardless of whether the patients had PATH-CR or not, when they looked across the groups, the patients who got perioperative durvalumab on top of the neoadjuvant gem-cis backbone had a benefit in EFS as well as OS. So again, these are sub-analyses, not extremely well powered for, but so at the moment, I think that it is difficult to say that you could eliminate the adjuvant component or based on PATH-CR somehow change your management. It's hard to tease out the adjuvant and neoadjuvant component of durvalumab for the proportion of benefit. But one thing I will say is that there was a separation in the EFS curve early on in the experimental arm, even before the radical cystectomy. So
Okay.
I think that these data are informed practice, and I think these data are quite strong for the benefit from adding the perioperative durvalumab, and we'll need to wait and see what the regulatory agencies think. But I think this is practice changing.
Appreciate that. I did want to call it, maybe if we had 1 minute for you to mention, I'm a sucker for new biomarkers, but maybe if you had a comment on, I think it was Checkmate 214, which is for KIM1 as the marker there. I think that's that's a mucin protein, I think. But you had messaged me earlier and wanted to, if you had any thoughts on that Nivo plus Ipi versus sunitinib, on if that mucin one or KIM1 is a good new biomarker within RCC.
Right. So KIM1 is a very interesting biomarker. This has been looked at in tumor tissue as well as a circulating proteomic biomarker. And suffice it to say that it has looked like a good biomarker for minimal residual disease already. This has been looked at in the adjuvant RCC trial, the Atezo trial, where they looked at it, where patients with KIM1 positive post-op were the ones that seemed to benefit from the checkpoint inhibitor, while KIM1 negative patients did not. So it's somewhat functioning like the MRD data we've seen with ctDNA in other cancers. So that was shown in the adjuvant setting. Now, what was shown at the GU ASCO symposium is the data for KIM1 in the metastatic setting from the Checkmate 214 trial. So this is a trial that compared Ipi-Nivo versus sunitinib many years ago, which has, of course, established Ipi-Nivo as standard of care in patients in the first-line setting with intermediate or poor risk disease. So what the investigators did from this Checkmate 214 trial is look at KIM1 in these patients. So the interesting finding, they looked at both baseline KIM1 before starting therapy, as well as baseline going to cycle 2, day 1. And the interesting thing was KIM1 at baseline was a poor prognostic factor. So the higher the KIM1, the worse the outcomes. This was across both groups, Ipi-Nivo as well as sunitinib. When they looked at the change from baseline to cycle 2, day 1, the findings here are interesting and diverge a bit for the two arms. So a decline in KIM1 was prognostic in the Ipi-Nivo arm, but not in the sunitinib arm. So this is probably from the differences in the mechanisms of how the immune checkpoint inhibitors work versus how the VEGF inhibitors work. But I think that these data need further confirmation and further, ideally, prospective validation to be able to use it as some kind of biomarker of MRD, at least in the immune checkpoint inhibitor setting, as a prognostic or predictive even for benefit in the adjuvant setting, and maybe early changes in the advanced disease setting are predictive of benefit, but somehow only in the immune checkpoint inhibitor, Ipi-Nivo setting, but not in the VEGF inhibitor setting.
That's activating my former preclinical scientist brain about the mechanisms that can be there at a cellular layer or level, that is, but we'll have to save that for another day because we've come to time. So really appreciate you, Dr. Sonpavde, highlighting some of these disclosures and key developments in the GU space. And if anyone's interested in the visuals we were looking at, please find LARVOL Clin on social media. And just want to say thank you once again, and hopefully we can get you back on in another couple months.
Thank you very
Thanks.
much for the opportunity.